This is part 5 of the hypertension pharmacotherapy lecture, and it is the last part of this lecture series. Alright, so what combinations are most effective for patients? So there's like a ton of different combinations, like you can literally mix and match almost any of these drugs. But the preferred combinations are an ACE and a calcium channel blocker, an ARB and a calcium channel blocker, an ACE and a thiazide, or an ARB and a thiazide. So we have an ACE or ARB as part of all the preferred combinations, and then either a calcium channel blocker or a thiazide diuretic. So using combination therapy rather than just keeping all these medications separately is a great way to help achieve adherence to therapy. The only combination that is really a no-no is combining ACEs and ARBs, right? Because this is essentially a duplication of therapy. We've got too much activity in the RAS system. Alright, so let's take a closer look at what these combinations actually look like. So this first slide is those preferred combinations, so the ACE-ARB plus a CCB, or the ACE-ARB plus a thiazide. And we also have ARB plus calcium channel blocker plus thiazide, which is a triple combo. Great, very effective too. So a common ACE calcium channel blocker I see used a lot is amlodipine with benazepril. So the brand name for that is Lotrel. And then a common ACE and thiazide combination I see so much is lisinopril and hydrochlorothiazide. So the brand name for that is Zesteretic or Prinazide. So again, there's a lot of combinations out there. I'm not going to ask you guys to memorize every single combination possible, but at least be familiar with these ones that are bolded because they are frequently used, and understand, why these medications are combined, how they're targeting different ways to decrease blood pressure, and why it wouldn't be safe to combine an ACE and an ARB. Those are the big takeaway points about combination medications, as well as understanding that combining medications is going to help tremendously with adherence. Alright, and the next slide here, again, one of the preferred combinations, just couldn't fit it on the other slide, is the ARB and thiazide combination. Then we have beta blocker and thiazide combination, not as preferred, but still a good combo. And then we also have spironolactone combined with HCTZ. Again, spironolactone is going to help hold on to some of that potassium that the hydrochlorothiazide is losing. Alright, so this is a recap image of how at least most of the medications that we talked about work, the big heavy hitter ones. So I'm sure you've seen, an image like this in a lot of the other lectures too. I just like to provide imagery to, complement all the wordy slides. So we have, the ACEs and the ARBs. The ACEs working here to block the ACE angiotensin converting enzyme. We have the ARBs working here. We have aliskiren directly inhibiting renin. We have the aldosterone receptor antagonist antagonizing aldosterone's effects. So all of these coming together, you can see how using different parts of the pathway are going to work in synergy and work together. We don't want to do too much though, and use an ACE and an ARB, or aliskiren and an ACE. That is too much in this one part of the pathway. And obviously the calcium channel blockers, beta blockers, the alpha drugs aren't here because they work in different areas, but this is at least a good image of the RAS system and where the drugs work there. So now we're going to move into resistant hypertension, hypertensive crises, special populations, all those things. So let's talk about resistant hypertension. What is the definition of resistant hypertension? So there are two criteria for when we would consider that a patient has resistant hypertension. So one is if a patient is on 3 antihypertensive medications at their full doses, and they have complementary MOAs, as in, they work in different systems. At least one of them is a diuretic. It's all this convoluted criteria. But if they're on 3 of these medications and they still don't have blood pressure control, then they're considered to have resistant hypertension. If a patient is on at least 4 medications and they do have blood pressure control, that is still considered resistant hypertension. Because the goal here is that we would like to not have this patient on 4 medications, but that is what they currently need to achieve blood pressure control. So those are the 2 different criteria for resistant hypertension. Now, treatment for this includes improving medication adherence, right? Maybe this patient's on 4 medications because 2 of them they're not even taking. They don't like the way it makes them feel. We want to identify and correct any secondary causes of hypertension, right? Because these medications that these patients are on work on primary hypertension. So if there is some secondary cause of hypertension going on and we haven't found it, that's why these medications aren't working yet. We want to address, other patient characteristics as well and look at the whole picture. Look at their lifestyle, rule out white coat hypertension, remove interfering substances, things that are acutely elevating their blood pressure before an appointment or even at home. Are they drinking a lot of coffee, things like that. So that is the general approach to treatment for resistant hypertension. We've already talked about, which drugs we might use in those cases. Alright, so let's talk about hypertensive crises. So hypertensive emergency, remember that is the one, had the typo on the last lecture, but thank you for the student that reached out to me to correct it. Hypertensive emergency is high, elevated, dangerously elevated blood pressure with end organ damage. Either they have it already or they're progressing towards end organ damage. So these patients we want to treat immediately with IV medications. We want to bring that blood pressure down quickly, about 25% within the first hour. So not like super fast, because that could cause damage too, but we want to decrease that blood pressure pretty quickly within the first hour, about 25%. And then after that, we want to get it to below 160 over 100 in the next 2 to 6 hours. Now, hypertensive urgency, again, there's no end organ damage. Doesn't look like we're progressing towards end organ damage. So we can treat these patients with oral medications, preferably that have a short onset of action so they can start working quickly, but we can treat them and lower their blood pressure gradually over 24 to 48 hours. So this algorithm here just shows that for a hypertensive emergency, we want to get them straight to the ICU. We want to evaluate if they have any dangerous conditions, aortic dissection, severe preeclampsia, or a phemochromocytoma crisis, anything like that. And we want to reduce the blood pressure quickly, but not, ridiculously quickly and cause some other problem. So we do it, the goal would be reducing the systolic blood pressure if they have one of these conditions to below 140 during the first hour and below 120 if they have aortic dissection. So aortic dissection, you guys can Google that. In hindsight, I wish I would have provided an image because it's really crazy, but the aorta basically has a tear in it, and blood that should be going through the aorta actually starts to pool out around that area. So I actually got to witness that in an inpatient setting one time after a patient had used cocaine. It was crazy reading the chart. I was like, you read about these things, you don't think they actually happen. But the patient was okay. They were able to use, IV medications to bring his blood pressure down. So a happy ending for that one. And then if they don't have any of these conditions, but they do have some sort of other end organ damage we've identified to classify this as hypertensive emergency, we can reduce the blood pressure up to 25% over the first hour and then to 160 over 100, like I said in this table here. Alright, so what are the IV antihypertensive medications that we would use for a hypertensive emergency? Pretty much any of the antihypertensive medications that come as IV. Most commonly, we will see esmolol used, just very effective. Esmolol and nicardipine, I would say, are the ones that I see used most frequently. And so this slide here, this is for FYI. This slide here, this image here, FYI, let me write that there. But it just shows, depending on different conditions that are going on, different IV agents would be preferred, but very, very niche thing to treat, so I'm not going to ask specific questions about which IV agent would be best for which condition. Just know that you need to use an IV agent, not an oral agent, to treat a hypertensive emergency. So let's talk a little bit about special populations and their respective blood pressure goals. So historically, most patients with hypertension were treated to a goal blood pressure of less than 140 over 90. But now, most patients are treated to 130 over 80. So historically, the goal was less than 140 over 90. Certain high-risk patients would have a goal of less than 130 over 80, but now almost everyone is targeted to that less than 130 over 80 blood pressure goal. because the evidence demonstrates a significantly lower risk of cardiovascular events with these lower blood pressure goals. So even though we can increase the risk of adverse events like hypotension, syncope, the electrolyte abnormalities we talked about, and even acute injury or some of the other, adverse effects of these drugs, the significant benefits of targeting to these lower blood pressures outweighs the risks. So for patients with diabetes, the ADA recommends a blood pressure goal of less than 130/80, so that's in line with the hypertension guidelines. For certain lower risk patients, we still see sometimes a less than 140/90 goal. The KDIGO guidelines recommend a systolic blood pressure goal of less than 120, so they're actually more strict than the ACC/AHA guidelines. And then same thing for pregnancy. The American College of Obstetricians guidelines recommends blood pressure goals of 120/160 for the systolic and 80/110 for the diastolic. So a little tighter control, and this makes sense, right? Because these patients are pregnant, and we want to make sure that we have tight control of, any sort of gestational hypertension or gestational diabetes for sake of the mom and the baby. And then for institutionalized older adults, we have a little more relaxed goal because, these patients are institutionalized, they're really sick, they're going to be at higher risk for these adverse effects. And during the time that we're trying to, treat them for whatever has them institutionalized, or, maybe they're a long-term care resident who doesn't really need that super tight control because of their life expectancy, whatever the case is, sometimes we have a little looser control goals for these patients. So here are some of the most compelling indications that we might start a medication for a patient instead of, the usual calcium channel blocker or thiazide diuretic for first-line therapy. If a person has heart failure with reduced ejection fraction, we want to start them on an ACE or ARB and then add a beta blocker as tolerated. And then potentially a diuretic to control any edema that is caused by the heart failure as well. And then add-on therapy after starting the standard therapy, the first-line therapy would be a mineralocorticoid receptor antagonist like spironolactone. For heart failure with preserved ejection fraction, kind of the same thing here. They might not need that add-on therapy. For stable ischemic heart disease, this is another situation where a beta blocker can be considered, part of that first-line group again, as well as adding an ACE or an ARB. And then we can add a calcium channel blocker if they have angina, and we can add a thiazide or a mineralocorticoid receptor antagonist as well. For diabetes, we definitely want to start these patients on an ACE or ARB because they're renal protective. They show good benefits for patients that have diabetes. But we can start them on a calcium channel blocker or thiazide as well. And for chronic kidney disease, definitely an ACE or an ARB is first-line therapy for these patients. And then for secondary stroke prevention, a thiazide or a thiazide-ACE inhibitor combo is preferred. Alright, so we're going to briefly discuss hypertension in pregnancy and certain conditions like preeclampsia that may happen in pregnancy. So hypertension in pregnancy can cause fetal growth restriction, maternal complications, organ damage, and even hospital admission. So this is why we have tighter blood pressure goals and control for patients who are pregnant and have hypertension. So pharmacotherapy is recommended for severe hypertension, which is systolic blood pressure above 160, diastolic above 110. And the first-line therapy for pregnancy is labetalol, methyl-dopa, and nifedipine ER, which we've talked about all those when we went over the different pharmacotherapy options. And of course, the ones that are contraindicated in pregnancy are ACEs, ARBs, and Entresto, because Entresto has that ARB component inside it. So preeclampsia is a complex multi-system syndrome. It complicates about 8% of pregnancies, and it's defined as elevated blood pressure and accompanying proteinuria, which is protein in the urine. So how do we manage this? We manage it the same way we manage hypertension in pregnancy, so using one of those appropriate agents. And then we also add on aspirin, baby aspirin, for patients that have high risk factors or if they have 2 moderate risk factors. And the risk factors we'll go over right now. So the high risk factors are listed to the left here, and then the moderate risk factors are listed to the right. So if they have any one of these high risk factors, they would be a candidate for the aspirin therapy. If they have at least two of these moderate risk factors, they would also be a candidate for that therapy. This is more for FYI and just to get the full picture of pregnancy and hypertension. But later on, when we have the special populations course, we'll go into much more detail about preeclampsia and eclampsia. So this slide for this block purposes is just for your information. Alright, so now we're going to talk about drug-disease interactions. So for example, different things that a patient could be on that would affect hypertension itself or their blood pressure itself. So not exactly interacting with other drugs that they're on or medications that they're on for hypertension, but literally exacerbating the condition. So first, alcohol. We have talked about this, so limiting alcohol to less than 1 drink daily for women and 2 drinks or less for men. Amphetamines can increase blood pressure, so we want to either discontinue or decrease the dose. It depends on what the patient's blood pressure is. And we want to consider behavioral therapy options for patients that have ADHD to see if we can wean them off these medications. Antidepressants, there's certain antidepressants that can increase blood pressure we talked about. So SSRIs are the preferred antidepressants for patients with hypertension because they don't really have that risk of increasing blood pressure. For atypical antipsychotics like clozapine or olanzapine, we want to discontinue or limit their use when possible. And similar to the amphetamines, we want to consider behavioral therapy instead if appropriate for the patient. Alright, then we have the NSAIDs. So NSAIDs we want to discontinue or avoid use. And we want to consider alternative agents like Tylenol or topical formulations. Sometimes it's even okay to use NSAIDs if they are topical, like topical diclofenac, because again, it shouldn't really have this systemic effect on blood pressure. But just to be on the safe side, Tylenol is the best over-the-counter pain analgesic for patients with hypertension. And as far as NSAIDs, baby aspirin is still an exception at this dose. It doesn't really have much effect on blood pressure, but it does have the cardioprotective effects that we're looking for when we use aspirin at this dose. Then for decongestants, we're talking about phenylephrine, pseudoephedrine. Both of these are in any over-the-counter cold, cough, flu medication you'll find, so really hard to avoid. Very important to tell patients, to look for these on the back of the boxes, the medications that they're getting. So if the patient absolutely has to use them, though, you can use them for the shortest duration possible. Avoid if blood pressure is currently severely uncontrolled. And we can consider alternatives that don't have decongestants in them. We can try nasal saline, we can try, steroid nasal sprays, antihistamines. All of those would be better options for patients than decongestants. Immunosuppressants, tacrolimus is the preferred one if a patient needs to be on immunosuppressant and has hypertension, because it has the lowest effect on blood pressure. And then systemic corticosteroids, we want to limit or avoid use when possible. And then again, consider, inhaled corticosteroids are okay because they're going to have that local action, and topical formulations too. So a great option here for patients that have hypertension and have a cold or the flu. We have quercetin products which don't contain NSAIDs or decongestants like some products might. These usually contain Tylenol for the pain relief and fever relief, and then an antihistamine for the congestion. So obviously, patients will know that antihistamines don't always work as well as decongestants would work, but these are just safer options for patients that have hypertension that are looking for some relief from their congestion. Alright, and then we have caffeine. So for caffeine, we just want to try to limit intake to less than 300 milligrams a day. If patients have uncontrolled hypertension, we want to avoid use until they have control again. Short-term use is associated with acute increases in blood pressure, but long-term use isn't associated with an increase in blood pressure, long-term or an increase in cardiovascular risk. But honestly, there's new studies coming out on, caffeine and whether it's good for you or bad for you and its effect on this or that all the time, so it changes. But in general, just if the patient's blood pressure is controlled, it's not going to affect their blood pressure long term, or affect their control if they're on their medications as they should be long term. So it's okay to have coffee, just try to limit it to less than 300 milligrams a day. Now, contrary to that, there are certain things that we just want to completely discontinue or avoid. I'm not going to recommend alternatives, just discontinue or avoid these. So nicotine, recreational drugs like bath salts, cocaine, and then certain herbal supplements like St. John's wort and other herbal supplements. So no alternatives here, no other recommendations, just stop taking those. Alright, so we are nearing the end here with follow-up and monitoring. So adults that have just started a new medication or we have adjusted their drug regimen should follow up monthly until control is achieved, as in until they are at their goal blood pressure. Once control is achieved, then they can decrease the frequency of their follow-ups to every 3 to 6 months. And then at some point, they can even space them out even further. Just depends on the provider's, comfort with how well this patient is doing, adhering to their medications, and any lifestyle modifications. We can see it, spread out maybe potentially to once a year. Just depends on how well controlled the patient is. Follow-up should also include monitoring of their home blood pressure, and also just taking a team-based care approach and making sure everyone is involved in the management of these patients, from their providers, the pharmacist, if they're talking to a dietitian, if they're, have a trainer to increase their exercise regimen. Team-based care is, the guidelines will tell you, is the most effective way to decrease blood pressure. And also telehealth strategies. When we have to see patients, say if you're trying to see them monthly until control is achieved, you might not need to bring them in for an appointment every single time. Or as you get more comfortable and they're really controlled, you might not need to bring them in for, their 6-month checkup. If you just want to see them once a year and then do 1 telehealth appointment a year or 2 telehealth appointments a year, this blending hybrid strategy of in-person appointments with some telehealth appointments is really beneficial for providers and for patients. It allows flexibility. No one wants to have to drive in the middle of traffic to get to a 9 a.m. appointment on a weekday. It's a big interference in the day-to-day life. And providers that see patients through telehealth can also see more patients in a given period of time because there's less, having to check the patient in, move them around the office, all of that. So super beneficial. Guidelines also talk about the benefits of telehealth strategies. And now pharmacists, we have a very unique role in helping patients achieve their blood pressure goals because we're the medication experts. So we can provide medication education on any new drugs that they're starting, talk about drug interactions with, medications that they're currently on, or drug-food interactions. We can offer motivational interviewing if we're identifying obstacles to adherence. We can talk about preventing adverse effects. Oh, you're on a diuretic. What time are you taking it? And if they're taking it at night, recommend switching it to the morning, things like that. And then we can also provide blood pressure monitoring. Like I said, a lot of these automatic blood pressure monitors are available in pharmacies, the sit-down ones, but we can also point patients to the ones that are sold that I mentioned are sometimes between $20 to $40. Very affordable devices that are easy to use. But if a patient's never used one before, they might ask for help setting it up, and you can be there to show them how to use it for the first time and enable them to be involved in their care and keep track of their own blood pressure levels at home. So pharmacotherapy and lifestyle modifications are most effective together. So even when patients are on pharmacotherapy and are controlled with pharmacotherapy, it never hurts to encourage healthy diets, healthy exercise regimens, stress management techniques, all of that, because it's the combination that is going to be most effective for getting patients to their blood pressure goals and also keeping them at their blood pressure goals. Alright, so we've made it to the end of the hypertension pharmacotherapy lecture. So hard to summarize 88 slides in one slide, but The main points about this lecture is that hypertension is a very common medical condition in the United States, and there's a strong relationship between elevated blood pressure and cardiovascular morbidity and mortality. So we should treat patients to a blood pressure goal of less than 130/80, which is appropriate for most patients, and that's because this blood pressure goal is going to provide the most benefits, has the most evidence for decreasing these cardiovascular risks. And there's a lot of different agents that we can use to get patients to these blood pressure goals, and therapy is always going to be individualized and unique to the patient's needs. And pharmacists are an important part of the team-based approach to optimizing medication therapy and lifestyle modifications, which in combination are going to have the best benefit for the patients. And here is a Quizizz learning activity for the rest of this lecture. You can find the link in the YouTube description or in the Canvas course. Here are the abbreviations for this lecture, and here are the references. So please go ahead and complete the accompanying student guide. I will also be posting some patient cases for you all to complete for Monday's lectures. But if you have any questions, please don't hesitate to reach out.